Very excited to be here with all of you today. I'm a pediatric nephrologist at the University of Utah and Primary Children's Hospital in Salt Lake City. But I actually grew up in the Denver area, so it's just incredible to be back here in my hometown and get to spend this time and meet new patients and families and have a chance to talk with all of you. So I kind of moved around for my medical training. I went to school in Omaha, Nebraska at Creighton University. And then I did my residency training in pediatrics in Madison, Wisconsin at the University of Wisconsin. And when I started my pediatrics training, I thought I was going to go into pediatric oncology actually, and it was early on in my second year of residency and doing my nephrology rotation in August, and there were patients with hemolytic uremic syndrome more associated with diarrheal illness and everything that piqued my interest in nephrology. So if it hadn't been for hemolytic uremic syndrome and kind of my fascination with the patients and the disease process, I probably would be giving talks at a pediatric oncology conference today. So that's kind of what got me involved in nephrology. So anyway, so today my talk, I wanted to kind of give an overview of hemolytic uremic syndrome and specifically aHUS, of course. And a lot of this information will be review for many of you. I know you're well educated in the disease process and medications and those things, but I feel like it would be remiss not to kind of go through that, as well as talk about treatment options and different challenges and updates kind of in 2016. And a lot's changed since my training in pediatrics and pediatric nephrology just in the last few years. So we'll get started. And then we're always supposed to say that we don't have any relevant financial relationships to disclose. So someday I would like to say so, but so kind of, as I was saying, in terms of the overview of the talk, you can't invite a kidney nerd to give a talk without having some slides about physiology and all of those things. So we'll go over the definition, some physiology, the clinical features that I know all of you are very familiar with, a little bit about the genetics, and Tara had a beautiful talk this morning in terms of going through things. So a lot of that will be review, but I appreciated her explanation and figures and all of that, which should make things easier to understand, as well as updates for 2016. So in terms of thinking about aHUS, so as you all know, is a rare life-threatening disease belonging to a very broad category of diseases that are called thrombotic microangiopathies. And if you kind of break down what those words mean, so microangiopathy literally means small vessel blood problem. And then the fact that the word thrombotic's involved, kind of you think of thrombus or blood clots being involved. And it really affects the smallest blood vessels in the body, so namely the kidneys and the brain obviously are affected. So in this diagram here, on the left panel, there's a normal blood vessel, and there's the blue rectangles there are the endothelial cells that line. And when everything's working well and the cells aren't damaged, they flow through the blood vessels very nicely. But with a TMA process, you get damage to the endothelial cells and platelet aggregation, thrombus formation, all of that clogs up the blood vessel and kind of prevents blood from flowing to the rest of the organ, which results in the kidney damage and involvement with the brains, things like seizures and that kind of thing that we were talking about earlier. So when we think about aHUS and kind of this broad category of thrombotic microangiopathies or TMAs, you kind of have to, the two main categories are TTP, which, for the adult patients, it probably when you presented, your doctors were initially, I'm sure thinking that you had TTP and, probably went through, plasmapheresis and all that till they got the testing back that, confirmed that you didn't have, a low Adams TS13 level and that kind of thing, and then, leads you down the pathway to thinking about atypical aHUS. And then in the pediatric age group, kind of the big differential, as I was alluding to, and what got me interested in pediatric nephrology, is what is referred to as STEC, or Shiga toxin E. coli producing related hemolytic uremic syndrome. So certain times of the year, and summer tends to be the peak season. In Wisconsin, where I was doing my residency, and in Utah, when kids are out and about, and kind of on farms or going to petting zoos, that kind of thing, they're exposed to this bacteria and to the toxin that causes this process. So when kids present initially, it's sometimes difficult to tease out, if they've got the diarrhea associated form, or if it's atypical hemolytic uremic syndrome. And then this slide will be kind of good to go back and refer to it, after later on in the talk, where it kind of breaks down the mutations that are related to the complement pathway versus that newly discovered mutation in the DGKE, or diacylglycerol kinase Epsilon mutation that Tara was talking about earlier as well. So in terms of what you see kind of from a pathophysiologic standpoint, so the classic triad, as you all know, includes what's called the microangiopathic hemolytic anemia. And what you see if we took a blood sample and looked at a blood smear, instead of having nice round blood cells everywhere, you get these blood cell fragments, or what are called schistocytes. So kind of the initial testing, when you get a basic complete blood count, you notice that the hemoglobin and hematocrit are low, the platelet count is low, but we're always wanting to know, okay, is there evidence of any blood cell breakdown or hemolysis, so those schistocytes and that kind of thing. And then there's another lab test that's called a lactate dehydrogenase, or LDH, that's elevated at the time patients are presenting with the disease, and then another test that's called the haptoglobin, that's often low for patients. So those lab tests are very important, for physicians when you're kind of trying to put the clinical picture together. And then other manifestations that can include brain injury, so things like seizures. Some patients develop strokes, heart involvement in terms of heart attacks or myocardial infarction, pericardial effusions, and then GI involvement with inflammation in the pancreas or pancreatitis. So until very recently, so in the last 4 years, when that other mutation was discovered, the designation of atypical aHUS was really reserved for a TMA that was associated with dysregulation of the alternative pathway of complement. And this figure will be familiar to you all from probably other presentations, as well as Tara's this morning. And the alternative pathway of complement is a very important part of our innate immune system, and kind of protecting us from bacterial pathogens and that sort of thing. So if this activation of the pathway is occurring, and if this is a bacterial cell surface, then that's a good thing. But when this process is happening, because regulation isn't there and it's your own cells, that's when everything that you see clinically develops. So in terms of thinking about this, and we'll kind of get to the next slide, goes through, but sort of where mutations can occur. The plus signs on this figure indicate gain of function mutations, so that occurs with C3 or factor B, or loss of function mutations, so factor H. And factor H is really the main regulatory component of this pathway. So the blue panel there just kind of goes through what I had mentioned on the other slide there. So there's some mutations that relate to loss of function, others related to a gain of function, and then there's another third category where there are mutations in genes that have been found, but it's not clear sort of how that mutation relates to this entity called factor H autoantibodies as well. And then the broader definition has occurred in recent years due to this mutation in the diacylglycerol kinase Epsilon, or DGKE. So in terms of talking briefly about the genetics of atypical hemolytic uremic syndrome, and you had a wonderful overview this morning, but I thought I'd kind of zero in on two of the mutations and then talk a little bit more about the factor H autoantibodies, and that wasn't discussed as much this morning. So I kind of figured I'd talk about the most common one, the newest one, and then the factor H autoantibody. So I apologize to anyone who has mutations and other things that we could, talk a little bit more about as well. So complement factor H was the first protein in which gene mutations were shown to predispose patients to atypical aHUS. And this, as you could see from the prior figures, protects the cell surfaces from activation of the alternative pathway of complement. It's the most common cause of aHUS, so in Tara's presentation this morning, she said around 22%, and that's probably more accurate as other ones are discovered, then the frequency of this drops, but it had typically been thought to be about in a quarter of patients. And most the mutations are generally heterozygous, so meaning you get that one affected copy, and the inheritance is autosomal dominant. So I won't go into too much depth about that, since Tara did a beautiful job explaining all of that. But this issue of incomplete penetrance plays in. So for family members that have the same mutation, it's about 50% whether they would actually go on to develop clinical symptoms as well. So in terms of factor H autoantibodies, so these bind to one end of the complement factor H protein, so the C terminus specifically, and then interfere with its ability to bind to cell surfaces. Therefore, the factor H can't do its job in terms of stopping the complement cascade. And it causes approximately 5% of cases of atypical aHUS. Some papers and other sources quote up to 15%, but what I saw was somewhere between 3 and 6%, so around 5%. Most patients with this present in childhood, and almost all, so about 90 to 95%, have homozygous deletions of the genes for complement factor H-related protein 1 and 3. But in terms of the mechanism whereby that mutation causes the factor H autoantibodies to develop isn't well known. So a little bit more about the long word that's hard to say, as Tara alluded to this morning. So diacylglycerol kinase Epsilon. So this was discovered in the last 4 years or so. I think the first publication was in 2013 that described this. So it normally prevents activation of this protein kinase C. So if that's activated, it can lead to thrombosis or blood clot formation. And this is an autosomal recessive disorder. And so far, there has not been any evidence that the complement system's involved with this mutation. So what we found is that treatment with Soliris or eculizumab or plasma therapy with plasma infusions or plasmapheresis is not found to be effective. So far, it seems to account for about 3% of patients with atypical aHUS, and it's definitely in the differential if patients present at a very young age, so generally, under a year of age, and so kind of testing is recommended for patients that kind of present in the first couple years of life. But that toddler age group is, often affected, with the STEC aHUS as well, so kind of teasing everything out can be, challenging for sure. So Tara did an excellent job kind of explaining, in terms of the genetics of aHUS and what sort of the risk is, for a family member who has the same mutation. So kind of the concept of the incomplete penetrance. So, in terms of kind of deciding whether to test or not, sort of related, to issues around kidney transplantation if someone was considering being a donor for someone who needed a kidney transplant, or women who are approaching childbearing age, since pregnancy can be a trigger, and those sorts of things. So in terms of kind of what, in this table I won't kind of go into too much detail, but the genotype or what mutation is present definitely affects what we see clinically or what the phenotype is. So for patients that have the DGKE mutation, we're seeing that at a younger age, along with complement factor H often. And then in terms of kind of the pre-Soliris era, risk of end-stage renal disease or death at 5 years was highest for patients with complement factor H mutations compared to others. Patients with MCP mutations tend to have frequent relapses, but the risk of progression to end-stage renal disease is less, and that kind of impacts, sort of questions about, more people. Go ahead.
Can you explain what MCP means? I mean, I see it on my labs, and it's always, I think, elevated, or maybe it's something that's low.
Oh, are you thinking of MCV on like your regular blood counts?
Oh, maybe that's it.
Because MCP is one of the proteins that helps regulate the complement cascade. It's synthesized by the kidney, so sort of the risk of recurrence after transplantation is lower, since you're taking out the affected gene. But I think MCV, so that stands for mean corpuscular volume, or so it's kind of related to the blood counts, and so if it's low, we think of things like iron deficiency anemia, versus if it's higher, anemia or low blood counts related to like B12 or folate deficiency or that kind of thing. So it's one of the things on a routine blood test. So because I was like, I doubt they're testing that very regularly. No, you're fine. So I think that was kind of all I wanted to say about that figure. Okay, so in terms of getting to treatment options, so really the mainstay of therapy, as you all are well aware, prior to 2009, was plasma therapy in the form of either plasma infusions or what we call therapeutic plasma exchange or plasmapheresis. And there's a recent publication in Pediatric Nephrology in 2016 where they sort of compiled, authors and physicians, scientists from many different countries in terms of consensus guidelines, for treatment of pediatric patients with atypical aHUS. And so kind of the top line, summarizes their thought that, plasma therapy is of uncertain benefit and associated with high risk. And the risk is really involved more with the technical aspects in terms of, having a central line in place and risk of infection or clotting, surrounding that. So kind of the second part of the slide there, they, looked at a series of about 71 patients that were treated from July of 2009 to December of 2010 in either a European or North American hospitals. And so of those 71 patients, 51 had received plasma therapy in some form, and 16 children experienced 17 catheter-related complications, so things like infection and thrombosis. But on the other hand, it did show that it induced complete or partial remission in quite a number of patients. But then, in terms of long-term outcome, obviously, just under half ended up having end-stage renal disease at 3-year follow-up. So really getting to, kind of the Soliris era, and it really has, made a tremendous impact on management of this disease. So it is a monoclonal humanized anti-C5 antibody. So the red X on the figure there indicates Soliris. So that's where it acts and binds. So binds to C5 and prevents cleavage of C5, therefore preventing it breaking into C5a and then C5b, which then can join with 6 through 9 and activate the membrane attack complex, or MAC, there. So it's able to block the pro-inflammatory effects of C5a as well as the pro-thrombotic effects of C5b through 9. And since 2009, so there's the 4 prospective trials by Alexion Pharmaceuticals and over 80 case reports that have shown that it is able to rescue kidney function or allow for successful kidney transplant for patients who had lost their original kidneys to the TMA process. So, and my apologies to the adults in the audience. I definitely have a pediatric slant on this talk since I'm a pediatrician. But kind of looking at one of the four prospective trials by Alexion, so study 5, or I hope I have the numbers correct, C10-003. So it was the first prospective study of pediatric patients with atypical aHUS. It included 22 patients and definitely had a focus on earlier treatment. So it did not require that patients first needed to receive any plasma therapy or quote unquote failed plasma therapy before they could be enrolled in the study. And over half of the patients received Soliris or eculizumab as their first line therapy. And then when they were looking at outcomes, so 64% of the patients had what they called a complete TMA response. So that meant normal platelet count and then normalization of the LDH, the marker of blood cell breakdown, with improvement of renal function. And they defined improvement in renal function greater than or equal to a 25% increase in their serum creatinine. And the figure on the right is just showing sort of kind of weeks of therapy on the bottom axis at 26 weeks, and kind of you can see the platelet count going up into the normal range. And then this figure here is looking at the outcomes in terms of kidney function, so in terms of improvement in the glomerular filtration rate as well. So of the 22 patients, only 2 out of the 22 were still on dialysis at 26 weeks of therapy. Some limitations of this particular trial, kind of for folks who've written about it in the literature, is that there was slightly fewer patients that had a complement mutation, so about 48% compared to about the 60 to 70% of kind of known patients with atypical aHUS. So it's kind of questionable if patients that had STEC aHUS were included in this, perhaps, not knowing, kind of what they may have had at the time. So general lessons from the 4 trials. So they discovered that it's definitely very effective in stopping the TMA process, allowing sustained remission, and results in improved or preserved kidney function. And use of it as an initial therapy or an early switch from plasma therapy may increase the chance of full renal recovery. And the treatment is generally well tolerated. And our nursing folks would probably have a good sense of sort of the percent of side effects. I believe there were a couple patients who developed meningitis in that initial group of 100 patients between the 4 trials, if that's correct. So in terms of looking at the case reports in the literature, and at this moment there's well over 80 with pediatric patients, or 80 in general, and then around 19 or more at this point in time with pediatric patients. And then interestingly, not so many. I mean, there definitely are papers with anti-complement factor H antibodies, but this particular group doing this review didn't include those. So 83% of those patients had a complement mutation, 66% required dialysis at baseline, and with the use of eculizumab, after a median follow-up of just over a year, all patients were in hematologic remission, so basically normal blood counts, normal LDH, and only 1 was on dialysis. So definitely very wonderful and positive outcomes. And definitely, I guess, just a comment that further studies, needed in terms of the newer mutation, the DGKE, in terms of kind of what, treatments are optimal for those patients. Any questions on what I've talked about so far? It might be a good time to stop for a second.
So I lost my kidneys quickly and early, but so have you seen, or is there anything out there saying that someone who was put on Soliris years later, who went dialysis for at least 2 years, that their kidneys had come back, or is it like more short-term patients?
So the question was, whether for patients who've been on dialysis for an extended period of time, if there's case reports of kidney function returning after an extended period of time. And there are some papers where, something that were like 6 months or that kind of thing in terms of, kind of the thought is, how long do you, give it to see if it, is working and that kind of
testing my old kidneys to see if they were doing anything? Or would that be like useless information?
Yeah, in terms of testing your old kidneys, and I don't know in terms of how that would be done if they, do you have, yeah.
It's a biopsy or what they do?
Yeah.
Just looking into it.
Right, yeah.
And not always things.
Yeah. Anyone else before we? Okay. So kind of the next portion of the presentation, I formulated questions that are coming up a little bit more frequently in terms of kind of, now in the post-Solaris era, kind of, what can guide therapy, duration of therapy, those sorts of questions as well. So what tests are available to monitor therapy with Solaris or eculizumab? So in terms of, tests, so the CH50, so that activity should be decreased and quite low with effective blockade with Solaris or eculizumab. The caveat is this cannot be used in patients that have a complete complement factor H deficiency, so meaning they're missing both copies of the complement factor H gene, so a homozygous mutation. And then in terms of another clinical test, eculizumab levels are being used a little bit more frequently. Their availability is somewhat limited, so in terms of certain labs that do these tests. I know Cincinnati Children's is one of them, and kind of, Moral and those folks as well. So in terms of, kind of thinking about when to do that, if a patient's just getting started on therapy, it, may make sense to check a level prior to when that next dose is due, a week after the first dose to make sure that things are effectively blocked. Issues that might come up that could explain why the level isn't where it should be with standard dosing, definitely in our pediatric age group. So if you have a patient whose weight is kind of borderline between two dosing ranges, that could certainly play in. For a patient who's initially presenting, if they have a lot of protein in your urine, you could potentially be losing drug, with the protein losses in the urine as well. And then there's a portion of patients that have a C5 kind of defect or anomaly where the drug might not bind as well to C5. So that's been shown in some Asian populations as well, so where the drug might not work as well. But in terms of kind of using the levels for routine clinical practice, if your regular labs are showing that everything's kind of quiescent, so to speak, so your platelet count's normal, your hemoglobin and hematocrit are normal, your LDH is normal, haptoglobin's normal. It's probably not of so much use to test regularly unless there's concerns for relapses. And
I started Solaris pretty quickly after being diagnosed, and I have been stable / protophoring according to my hematologist, which is perfectly fine by me. But every time I meet up with him, it's always a question of how much longer do we do this? Since I have no mutations, and I'm otherwise seen with something like I don't have any high blood pressure anymore. Everything is totally normal. But I guess that's my question: is when do you start messing with the doses or anything like that? So
it's like you were planted to be a
transition
for some So her question was kind of, she's been very stable on her dose for over a year now, and kind of, without any other organ effects at this point in time. So kind of when could you start thinking about changing the dose, spreading out the interval, potentially coming off therapy, those sorts of questions, and definitely I think more people are asking. So I said she's a great segue for the next part. So in terms of the question, so for a patient in remission, can the interval between doses be increased? So kind of what the ideal would be is that you have permanent C5 blockade that's achieved with ongoing use, and that's what Alexion in their drug monograph, et cetera, states as well. So definitely changing the dosing, the dose itself or the interval between doses can leave a patient, without effective complement blockade. So they definitely provide counseling on the website in terms of kind of what to look for symptoms and kind of thinking about, those risks as well. And, one thing that may come in handy are, monitoring, labs such as the CH50 activity. So if you, try to decrease the dose or space out the, the activity or the dosing interval, you would want to maintain that level very low, that things aren't very active. So kind of doing that without checking obviously would be, a bad idea. It looks like you guys have a question.
I guess I missed it. What is CH50 and how do they measure it?
Yeah, so CH50 is complement, 50. So it's kind of a combination of C3 and C4. So the total kind of complement activity. So it's a test that's often checked when patients initially present along with the C3 and C4 level. So it's a little bit more standardized or routine lab test that doesn't need to go off to Iowa or Cincinnati or those kinds of things. So it can be done in most routine like research or clinical labs. Yeah. And yeah, I was to say, honestly, I haven't, for my patients, ever really delved into checking, this to kind of go this route. So, yes.
Is it different than the complement titer testing? Or are they two different things?
It's very similar to that. So you can kind of get, C3 level, C4, and then this is the kind of total complement level as well.
Is that also going to tell you whether this is a C5 blockade? How do they know that?
Well, the fact, the activity is quite low. So you're using it as a surrogate.
Tell whether you're in C5 blockade?
Right. Exactly. Oh yeah, go ahead.
Different symptoms present with different, like say one patient is factor H and then another patient could be CH50. Do different patients react differently to the Solaris? I mean, with different side effects? Because I am just tremendously fatigued. I sleep for 24 hours after taking it. My bones hurt. Get really bad headaches.
They went away. Eventually they went away. I mean, the doctor said, well, before you come, take meds. And I started that then I started waiting to see whether we could get a headache, and I took it after, and then after about 6 months, I didn't get it.
Yeah, I've been on it over a year. I was just wondering.
Yeah. So her question was, do kind of different patients with more of the question if it's mutation related, or I think just like any drug or medication that patients take. So there's a broad range of different side effects, and there's some that are more common in general than others, and every patient's a little bit different in terms of how their body reacts to different things. My group of pediatric patients has done really well with it with very little side effects, but I might just be, and they might be lucky with in terms of things. Our nurses in the back might have some thoughts with talking with patients, kind of from around the country really, and that kind of thing to add.
Individual, I've never, anecdotally, I've never seen anything with different mutations, different symptoms based on mutation. like you said, it has to do with some people can take Tylenol and they have no problems. Other people take Tylenol and it gets tired. They get very tired, and other people take it, they get stomach upset. And it's kind of like a variation. It just happens to be how you react to it.
Can you repeat that so it gets on the mic?
Yeah. So she was just saying kind of, anecdotally, she hasn't kind of been talking with a lot of patients, around the country, seeing, different mutations, being more prone to, headaches or any other, symptom than other patients, and just how, patients are different even with a routine headache, whether Tylenol works or doesn't, and that kind of thing. Hopefully that was a good summary. Yeah.
I have a rationale. I want to know the rationale behind putting having my son has H. He has Diacylglycerol every 3 weeks, but he's also on Cellcept. But it never really it's not into they didn't diagnose him as chronic kidney failure anymore. It's acute kidney injury. So why would he take anti-rejection medication like Cellcept if it had already kind of his kidneys came back, they're working fine, his labs have been all within normal range, just like as yours. That he's been doing great, and he's actually got 3-week infusion. But why would what's the rationale between taking the Cellcept if he's having rejection to kidneys?
So do she was asking for her son. He's getting Soliris every 3 weeks, is doing better now. He's also on mycophenolate or Cellcept as well, and sort of wondering what the rationale for that is. I think I would need to know a little bit more information about what kind of mutation he has, or if he has the factor H autoantibodies.
He has the factor H antibody, but he doesn't have a mutation. Okay.
So I will kind of get a little bit into more about the factor H autoantibodies, but what was that? Sorry. Her son, or I don't believe so. No. Yeah. So it sounds like his kidney function's recovered. So. But yeah, so it's been shown, and I'll get into it in a little bit later slide, in terms of for patients with factor H autoantibodies, kind of without immune suppression, the outcomes aren't as good. So it basically reduces the antibody levels is the point of that medication. And I've used it myself in a similar patient and everything. So I'm guessing that's why they're using it, but. Okay, so in terms of the question about what should the duration of therapy be, and as I said, there's no position on the full prescribing information of the FDA in terms of kind of stating what the duration of therapy should be. And then, they definitely provide information about the risk of relapse after discontinuation, like I was mentioning. And there are some reasons to perhaps reconsider the concept of lifelong treatment, which I have on the next slide. But the caveat is experience with withdrawal is limited. So I know it's difficult to read the information on this slide. So in terms of things to think about, the top panel is the risk of relapse, which I have kind of blown up in larger on the next slide. The risk of vascular complications, thinking about the risk of meningitis, under therapy, and then just kind of thinking about treatment burden, cost, inconvenience, those kinds of issues that play into your day-to-day lives, for sure. So in terms of the risk of vascular complications, so in terms of kind of long-term cardiovascular health, there's not great data kind of comparing that to cardiovascular disease related to chronic kidney disease. So there's really not enough kind of demonstration of this effect to make it worthwhile to say that that's a reason to withdraw Soliris. And definitely, as you guys know, getting vaccinated or taking antibiotic prophylaxis, definitely protects you, against meningitis, but the risk is still there. So if that's something that's kind of too much of a risk for someone, it might be a reason to reconsider things. And then in terms of just the treatment burden and cost, in terms of lifelong infusions, going to an infusion center every couple of weeks, unless you, as Sarah was able to do, arrange for home health, which I think was awesome for you. So in terms of looking at the risk of relapse, so kind of in terms of thinking, sort of the risk with the disease itself, and then what's, sort of been shown in, limited cases of withdrawal of medication. So in one group, patients with complement factor H mutations, 4 of those patients ended up relapsing when Soliris was withdrawn. So they kind of, sort of the author's recommendation is to, proceed cautiously in that regard. Patients and particularly children with MCP mutations, despite a frequently relapsing course, generally have a pretty favorable prognosis. But if they present with a relapse, there is a risk of, end-stage kidney disease of about 17% at 5 years. So having a relapse, does involve, some risk. But if you kind of feel like you can, monitor for that and kind of initiate, Soliris again, with a relapse, that might be more, favorable to a family than just continuing for years on end and that kind of thing.
What do they look for in the urine then?
So looking for blood and protein in the urine. And that, I was going to say, you'd have to kind of document that patients don't have baseline microscopic blood in the urine. So if you kind of have that all the time, it's not going to be, helpful. So you'd have to have a completely normal urine, on therapy to make it worthwhile to monitor. Yes.
Speaking of protein in the urine, what would be a concerning amount if you go from normal kidney function to not so good? Would it be like +1, +2 as far as protein levels in
So kind of normal. Oh yeah, sorry. So in terms of what would be concerning in terms of an amount of protein in the urine, kind of if you're monitoring at home and sort of what would indicate, a relapse. So I would say normal is tracer negative for protein in the urine. In kids, there's an entity that's called orthostatic protein in the urine. So kids can have a little more protein in the urine during the day because their filters are a little more leaky for protein. So we always kind of check a sample first thing in the morning, which I would kind of advocate for an adult patient as well to kind of, do that consistently. So yeah, certainly if you're seeing, go from, trace to 1+, then 2+, that would be, concerning.
A doctor, if they saw a 2+ after previous weeks of being no trace, that would probably be a red flag.
Right. And then, in the adult world, they like to do more 24-hour urine collections to actually quantify the amount of protein. So there's sort of, guidelines in terms of, more than half a gram or that kind of thing as well. So I'm not an adult kidney doctor, so so I don't want to lead you astray. But so in terms of kind of the question from the back row, in terms of treatment for patients that have factor H autoantibody related aHUS. So this is a kind of proposed treatment algorithm, and they basically said, kind of on the bottom, a caveat that further studies are required to kind of document because there just aren't enough patients and enough kind of data in terms of, these treatment protocols. To demonstrate, but essentially an important component, of this is the concept of immune suppression as well to lower the antibody titer. So you can use that in combination with Soliris or eculizumab. So kind of on the far right, they're kind of talking about if you have severe other kidney manifestations, so brain involvement or a heart attack at the time of the aHUS episode, they're saying that you would want to consider combining Soliris with maybe plasma exchange and then initiating immune suppression. So the list has different immunosuppressive meds. So cyclophosphamide or Cytoxan is a chemotherapeutic agent. So there's some concern within it. It was a medication that was used for a long time for patients that had lupus involvement in the kidneys. It's definitely used kind of in the cancer setting as well. It does kind of affect your, you have to basically talk with patients about risk for fertility and that kind of thing long term. So the fact that there's other drugs like Cellcept or mycophenolate that kind of work similarly, that don't have those side effects and impact on long-term fertility, and especially for pediatric doctors, that's important to us because we're meeting these kids when they're young and trying to think about their long-term health as well. So kind of on the left-hand side, it's talking about using immune suppression along with eculizumab, and then considering stopping Soliris or eculizumab when the antibody titer is low, and they kind of would say, patient's stable, for a year or two, before you consider doing that. Okay, so just a little bit about kidney transplant in atypical hemolytic uremic syndrome. So fortunately, for a lot of patients, this issue doesn't come up as much anymore in the post-Soliris era. So the risk, prior to having terminal complement blockade was about 60%, kind of overall, and definitely mutation dependent. So kind of issues today, continue to include, considering the choice of donor. So you obviously don't want to take a living. We generally, for our pediatric patients, do prefer a living donor over a deceased donor, just because the longevity of the graft is greater. But certainly you don't want to, take a donor who has the same mutation, because the risk would increase. And then basically the other important thing is preventing recurrence post-transplant, so kind of doing the transplant under the cover of eculizumab, as Alyssa and her family were talking about with us as well. And obviously the goal is to provide the best long-term outcome and graft function possible. Okay. And then the issue of combined liver and kidney transplant in the setting of atypical aHUS. So this definitely, I think, occurred a little more often in the pre-Soliris era, and definitely, having taken care of patients who received a combined liver kidney transplant for other disease processes, it's not, kind of an easy road to go down. So really, for patients that have mutations in the complement factors that are synthesized by the liver, so complement factor H, B, and C3, this is the only option to, really, quote unquote, cure, the disease. That being said, if you have, your kidneys had failed, and, in the setting of eculizumab, you can do just do a kidney transplant under the cover of eculizumab, and that would probably be what a lot of pediatric providers would lean toward, but there's definitely certain cases where this would be considered. So this author in Pediatric Nephrology published about a series of 20 patients that had those mutations. 19 underwent a combined liver kidney transplant, and 1 underwent an isolated liver transplant. They received either plasma exchange or eculizumab pre-op, and kind of in post-op follow-up, 16 patients were doing well with both of the grafts functioning, but there were 3 patients who ended up dying in the post-op period, and kind of the time frame was variable with that, but generally related to vascular complications with the transplant. And I'm just curious if that topic has come up for anyone in this room.
For the liver kidney transplant? My son, we're originally from California. He got his original work up at UCLA, and they had talked about it. And personally, as a parent, I was just like, just because you've got two transplants, so 2 rejections can go on, and which one you don't know. Right. So that was just more on personal choice.
Okay.
That was pre-Soliris.
Okay. Yeah, thank you for, I was gonna say, I think this came up definitely a lot more often before Soliris, but just was curious what, people's experiences had been with that. Oh, yes, go ahead.
My wife needs a kidney transplant, and the hospital that we saw, actually the surgeon had brought this up about doing liver kidney combination, and both my wife's hematologists and nephrologists said absolutely not. It's not broken. Why put her through that in case they both reject her, so just have to see how it goes. But both her doctors said they would not suggest that under any circumstance.
Oh. Okay. So in summary, obviously a lot of progress has been made really in the last 10 to 15 years, kind of in regard to, the diagnosis, treatment, and kind of contemplating these long-term management questions. There have been new discoveries in complement-independent forms, that DGKE mutation. And really, we kind of left with ongoing questions, mainly, kind of this question of duration of therapy. Can the medication be withdrawn? Kind of other therapies with the factor H autoantibodies. And then really for patients with the DGKE mutation, are there treatment options, since it seems like eculizumab or Soliris and plasma therapy don't seem to be effective, and these kids are, presenting at a very young age, and kind of what to do with that as well. So I just want to thank you for your attention, and hope you enjoy the rest of your stay in my home state of Colorado. So I took these pictures myself, well, not the Denver city limit one, but the two kind of on the left and right are from Garden of the Gods in Colorado Springs, and then, kind of a sunset at the Rockies game a couple years ago when I was home for the summer. So since I know everyone's going to be headed there tonight, so enjoy. And if anyone has any other questions, I'll take those now. And then,
How frequently should titer testing be done?
so I think so are you talking, oh yes, yeah, so the question was how often titer testing should be done, and I'm assuming you're talking about for factor H autoantibody titers. So I think it really depends on kind of what the overall treatment plan is, and that sort of thing. So for my patient with factor H autoantibodies, when we were starting on immune suppression, we were following, every month, initially, but then once the patient was very stable, on the treatment plan, we kind of decreased the frequency at every, 3 to 4 months or so quarterly.
So if there is no treatment plan?
That's a good question. I would probably say, it would make sense to check at least quarterly. I know I should probably know what the cost of the lab is itself, because obviously that gets sent to Moral, so I don't know in terms of what the patient, depending on the insurance plan, what the cost is. But yeah, I would probably say at least 3 to 4 times a year, just to keep track. And then certainly if anything changes clinically, for sure. Any criticisms from the adult folks? A pediatrician give the talk, so. Okay.
No other questions?
Okay. Well, thank you guys, and I hope, it's definitely a very broad topic, and you guys are very knowledgeable, so I hope you learned a little something from me, so appreciate your time. Thank you.